Good morning, everyone. I'm Dr. Tara Kiran. I'm a family physician at St. Michael's Hospital and the Vice Chair for Quality and Innovation in our Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions now at our 52nd session together with the Ontario College of Family Physicians. And I'm going to turn it over to their president, Mekalai Kumanan, to introduce the session. Mekalai.
Thank you, Tara. Good morning, everyone. Really pleased to be here today. We have a really timely session lined up for you today. And I'd like to just take a moment to thank our panelists and for all of you for being here. Just a reminder that this is a Main Pro accredited session and details will be sent to you by email. Next slide. So I'll just read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from the lands traditionally used by the Haudenosaunee, Anishinaabe, and Neutral peoples.
Thanks, Mekalai. I'm sharing here some data from my colleague Janet Smiley's team at the Well Living House. As some of you know, Janet Smiley leads this work called a community-driven health survey for Indigenous people, Our Health Counts. And she's really found through that survey some important statistics, including just how few Indigenous people living on urban lands have access to family doctors or primary care. And so what you can see here is this graph that, says that, approximately 90% of adults, and this was, a few years ago, had a regular medical doctor that they could seek care for. In contrast, only 63% of Indigenous adults did. Lots of talk these days, of course, about everyone not having struggles finding a family doctor, not having enough family doctors, but just a reminder that this issue disproportionately impacts Indigenous people and some of our other vulnerable groups. Next slide. So of course, our session today is building on our past sessions. And if you want to view our past sessions, you can go to our website. Our today's session, along with the slides, the Q&A, and some resources will be posted on our website soon after the session, usually the same day for the video and the slides. Next slide. So I'm really delighted that we can bring you this really timely panel. We know it's a very stressful time, and we're hope that today's session will help you to manage these issues in your practice effectively. Next slide. I'm going to turn it over first, next slide, to Tasha to just introduce yourself.
Hi, everyone. I'm Tasha Stoltz. I'm a general pediatrician. I work at Grand River Hospital in Kitchener, as well as Cambridge Memorial Hospital. I also have a consulting outpatient pediatric practice. I have a faculty position through McMaster, but should not conflict with the talk that I'm giving today.
Thanks, Tasha. Joan?
Hi, everyone. I'm Joan Chan. I'm a family physician who practices in Guelph. I am the chair of the board of the Guelph Family Health Team and receive honoraria from those. I have recently held other board positions, but didn't receive any financial support from them. And I am also getting an honoraria from this talk today. No conflicts.
Susy.
Good morning, everyone. I'm Susy Hota. I'm an infectious diseases specialist at University of Toronto and University Health Network. And I'm also the medical director of infection prevention and control at the University Health Network. I have received grant funding from Finch Therapeutics Group. There's no conflict in terms of anything I cover in today's talk. And I've also received an honorarium for this talk.
Thanks, Susy. Mekalai.
Thank you. My name is Mekalai Kumanan. I practice in Cambridge. I sit on the Echo Chronic Pain and Rheumatology Advisory Board, and I also receive a stipend for my role at the OCFP, neither of which poses a conflict.
Liz.
Good morning, Liz Muggah, family doctor in Ottawa, and I am the senior clinical advisor for primary care now at Ontario Health. So that is my job, but there are no conflicts for this presentation.
I'm lucky to have some research support and grants, which I've listed there, none of which pose a conflict for today's conversation either. Next slide. So as usual, just ask you to put your questions in the Q&A, and we're going to do our best to get through as many as possible. Obviously, we're going to prioritize the ones that get the most thumbs up. So it's best to give other questions a thumbs up if you like them. Then we know that they're ones we should prioritize rather than put the same question in worded a slightly different way. Of course, please use the chat because we always love to hear your thoughts, your reactions, your resources and tips. That's a really important part of this community to connect on the chat. We're going to start today by having Dr. Tasha Stoltz and Dr. Joan Chan really talk about managing pediatric respiratory illness in the community, diagnosis and management, but then also just some practical tips on kind of what's happening in the office. We are then we're going to take some Q&A after that. We're going to share with you some resources that we hope are helpful for your practice. And then we're going to move to Dr. Susy Hota, who's going to give us the overview of COVID, what's going on right now, what do we need to know in terms of the latest and variants, boosters, etc. So without further ado, I'm going to turn it over to Tasha.
Thanks so much. I'm really happy to be here. Thanks for having me here today. I will say I'm just coming off of a 24-hour call. So if I start becoming incoherent and talking gibberish, please, let me know. Anyways, in the last few weeks, we've been seeing a lot more pediatric patients with respiratory infections at the hospital. So I'm sure that you're all seeing even more kids who are not ending up in the emergency department. So thank you for all that you do. Next slide, please. I'm going to spend about 10-15 minutes today just to give a very quick rapid fire primer or refresher to common pediatric respiratory infections. Next slide. I'm sure that you've all been experiencing this firsthand, but it's all over the media these days about how not only are our numbers increasing, but the acuity of the presentations are also fairly high. Next slide. This is a quote from a pediatric intensivist in the US, quoted in the Atlantic article that I had screenshotted there. It really is the worst it's been for us throughout most of the pandemic. Next slide. This graph just shows you the number of emergency department visits for kids aged 0 to 4 and then 5 to 7 on the lower graph. The black line is the average number of visits during the pandemic, while the other colors represent various averages in the years before the pandemic from 2015 to 2019. Basically, you can just see the numbers are much higher now than they've been for quite some time. Next slide. This slide is similar, however, it's actually the number of admissions, which is really stunning in that it's truly higher than it's ever been since 2015, which is just shocking to me. Next slide. So hopefully I'll give a quick rundown of the various respiratory infections. And as a quick overview, just in very simplified fashion, this is the things that I'll be talking about today. Next slide. We'll start off with upper respiratory tract infection. So typical symptoms include sneezing, a stuffy or runny nose, headache, sore throat, and maybe a cough sometimes. It is always viral in cause. Your diagnosis is going to be clinical. A nasopharyngeal swab is not necessary and ultimately doesn't change management anyways, which is going to be supportive. No evidence whatsoever for oral, inhaled, or intranasal steroids. And since the etiology is usually viral, no point for antibiotics either. Next slide. So croup is an acute onset upper airway obstruction secondary to a viral infection. Usually it's caused by parainfluenza, but really can be caused by any virus. And in particular, we were seeing lots of COVID causing croup symptoms. Typically, it's in kids between between the ages of 6 months to 3 years. If it's presenting outside of this age group, typically there's either some complicating past medical history or you should be thinking of an alternate diagnosis. Most kids will have mild symptoms and will resolve in 3 to 7 days. Symptoms include rapid onset of a barky cough, inspiratory stridor, hoarseness, and respiratory distress. If the patient looks toxic, is drooling, having dysphagia, then that is not croup, and you need to be thinking of other differential diagnoses for upper airway obstruction. Next slide, please. Your diagnosis is going to be clinical, so no investigations necessary. For the majority of patients presenting to your office, they'll probably have mild croup, and you can treat them with 1 dose of oral dexamethasone. If their croup is moderate to severe, for example, if they have stridor or worker breathing at rest, then they need to go to the emergency department. Again, croup is viral, so no role for antibiotics. Usually kids will improve within about 3 to 4 hours of oral dexamethasone, and then the effect will last about 24 to 48 hours, at which point they'll be over the worst part of their illness. Next slide, please. So bronchiolitis, which is a hot topic these days, is a viral lower respiratory tract infection in young kids and can be caused really by any virus. RSV is obviously the most common and most well-known. It's all over the media these days, but influenza, parainfluenza, COVID, etc., can all cause the same constellation of symptoms. Bronchiolitis is characterized by acute inflammation, edema, and obstruction of the small airways and mucus production. Usually there's a 2 to 3 day prodrome of fever, cough, rhinorrhea, and that then progresses to wheeze, crackles, and a variable degree of respiratory distress. Usually that's worse about day 4 or 5. But really the severity can vary from quite mild to impending respiratory failure. Next slide, please. It's a clinical diagnosis based on your history and physical examination. So a chest x-ray is not necessary for diagnosis and typically will just show you non-specific perihilar infiltrates. Typically, we would only really do chest x-rays in severe respiratory distress to rule out alternate diagnoses. Labs and an NPS are also not necessary for mild cases that you'll be seeing in your office. Bronchiolitis is a viral and self-limiting disease and can be managed with supportive care at home for mild cases. And honestly, even kids who are admitted to hospital are managed supportively with hydration and respiratory support. Gentle nasal suctioning can be really helpful in younger infants and typically actually something I do suggest to parents prior to feeding to ensure that infants can maintain their hydration, given that they are obligate nose breathers. At the same time, I still counsel parents that over suctioning can cause edema of the nasal mucosa and worsen respiratory distress. So not to be like too vigorous with their suctioning or to do it too often. No evidence for the use of steroids, antibiotics, or antivirals in the treatment of bronchiolitis. There's also no evidence for the use of Ventolin. Infants are actually thought to have inadequate beta-agonist lung receptors and immature bronchial smooth muscles, which often makes Ventolin just not a useful therapy in general and makes them hyper, jittery, and super behavioral instead. In bronchiolitis also, the airways, like if you go to the pathophysiology, the airways are obstructed rather than constricted, which is the case in asthma. I will say though, in practice, I think a lot of us actually struggle with doing nothing, especially in cases of severe respiratory distress where we're escalating respiratory support. And oftentimes the diagnosis of bronchiolitis can be pretty similar to first presentation of wheeze and asthma. So for older infants and children who are presenting severe enough to require admission and respiratory support and have a strong personal or family history of atopy, some of us will do a trial of Ventolin in hospital to see if the wheeze is truly Ventolin responsive. So that's probably something that you'll be seeing a lot for your patients who are ending up in hospital, but it's probably not something that's needed in mild bronchiolitis that you'd be seeing in an outpatient setting. Next slide, please. So bacterial pneumonia. So kids will have higher fevers, cough, and generally appear sicker than your viral illnesses. Again, typically a variable level of respiratory distress. Most common bacteria in kids is strep pneumo, mycoplasma pneumonia, and chlamydia pneumonia are other common causes in like school-aged kids. Chest x-ray is not indicated in kids who are wheezing because the diagnosis is either going to be bronchiolitis or asthma. However, if you suspect a bacterial pneumonia in a child, so significant fever or physical exam findings of crackles, then a chest x-ray would be indicated to confirm the diagnosis. Bacterial pneumonia would typically show as a focal consolidation or worse, although for atypical pathogens, they can have bilateral infiltrates. And really the classic finding there is when you have like the chest x-ray that's worse than the patient, where the patient has fairly mild symptoms, that would be more in keeping with your atypical pathogens. NPS and labs, again, not typically indicated for outpatients, and we would really only do that in severe respiratory distress for hospitalized patients. Next slide, please. For uncomplicated outpatient community-acquired pneumonia, amoxicillin is the treatment of choice. Typically, if you actually look at your pediatric drug formularies, your amoxicillin dose ranges will go from 40 to 90 milligrams per kilo per day. However, because of actually local resistance patterns for strep pneumo, higher dosing is recommended, but I would check with your local antibiogram data. Treatment with for atypical pneumonia is actually a little bit more controversial. because most kids actually recover without antibiotics, but for kids who are severely ill or have persistent cough, then we may treat with macrolides, of which azithromycin is usually what we would use. Kids usually improve within 48 hours of starting antibiotics, and for most cases, a repeat chest X-ray is not necessary unless there's clinical worsening. Next slide, please. So asthma is by definition recurrent wheeze, which is responsive to bronchodilator treatment. To be honest, I could probably talk for like 3 hours on just asthma and certainly don't have that time today. So I put some resources on the slide here of some Canadian Pediatric Society guidelines on diagnosis and management of asthma in various age groups, as well as management of an asthma exacerbation. I'll talk briefly about mild asthma exacerbations, which you're most likely to see in your office setting. Next slide, please. So again, if you have someone presenting with an asthma exacerbation to your office, the diagnosis is clinical. Honestly, like I said, if you hear a wheeze on exam, a chest X-ray is probably not necessary. Patients should be encouraged to use their rescue medication every 4 hours regularly during the exacerbation. If they're needing it more frequently than every 4 hours, you need to tell them that they need to go to the emergency department. You can prescribe oral steroids for an asthma exacerbation, either prednisolone or dexamethasone. They just note that there are different doses and different duration of treatment. The other thing to keep in mind is that not all pharmacies will have the right concentration of dexamethasone. So for bigger kids, it can be like a lot of volume to drink, like a whole cup or more, unless they fill their prescription at a compounding pharmacy. So for that reason, oftentimes we'll use Pediapred instead. For kids who take an ICS at maintenance, there is no role for increasing the dose during an exacerbation. And for kids who are not on ICS at maintenance, who have mild intermittent asthma, there is no evidence to start ICS just during an exacerbation. Next slide, please. Other things to keep in mind in kids with asthma is to make sure that they have good environmental control, avoid their triggers, and manage any other comorbidities that they may have. Asthma management is so confusing for families because there's all sorts of different colored puffers and they have no idea how many puffs of what to take. So really everyone should have a written asthma action plan because most parents will forget everything you say the moment they walk out the door. Please make sure that kids who use a metered dose inhaler have aero chambers and that the families know how to use them. Keep in mind that it takes 4 to 6 weeks for there to be any effect from ICS use, and please counsel parents accordingly. I often have parents coming in who stop it after 2 to 3 weeks and complain they see no difference, and well, yeah, because it hasn't started working yet. Side effects, again, are pretty common, so please counsel around those as well. Next slide, please. I imagine post-viral cough is also something that you all see very frequently in your offices, and it's something that certainly causes parents a lot of distress. Honestly, I wish I had a magical cure for the post-viral cough. All I can say is manage expectations. I usually tell parents of kids who are hospitalized upfront that their cough can last 4 to 6 weeks, and hopefully that prevents them from at least going into your offices and booking an appointment to talk about their cough. Really, in otherwise healthy kids, no investigations are required unless the cough lasts for more than 6 weeks and it's the same cough and not a reinfection or something else, or if it's associated with other worrisome features. Over-the-counter cough suppressants, not recommended in kids, especially those under 6 years of age and often associated with adverse outcomes. Honey does actually have good evidence for use in kids over 1 year of age as a natural cough suppressant. Otherwise, I just counsel families around using humidifiers and avoiding triggers like cigarette smoke and aero allergens. Next slide, please. And other quick tips around questions I often get with regards to hydration, it really doesn't matter for older infants and kids. Electrolyte maintenance solutions like Pedialyte are great. However, kids often actually don't like the taste and it can be quite cost prohibitive for families. There are lots of studies that show that half-strength apple juice is just as good as electrolyte solutions. This is probably the one time I recommend juice for kids. Frequent small amounts is key rather than expecting kids to be drinking whole bottles or whole cups. Newborns and younger infants, of course, should stick to breast milk or formula and no juice for them. With regards to assessing hydration, my threshold for parents is if they have no pee in 12 hours, then they have to come to the emerge because at that point they likely need IV fluids. I'm sure you all have also been dealing with the Tylenol and Advil crisis. I get asked this on a daily basis. No prescription is required, and at least for our region, I've been directing many families to compounding pharmacies. For families who do have access, you can ensure that the dosing is appropriate for the child's weight based on the concentration and not just the age. Most kids are actually underdosed based on the recommended dose on the bottle. I think it also helps to educate parents that fever is actually a normal response and doesn't need treatment unless the kid is irritable or otherwise affecting feeding, etc. Next slide, please. So just to conclude, a quick summary on the different respiratory infections today. So diagnosis really is in the history. Chest x-ray is only helpful if you're suspecting a bacterial pneumonia or to rule out other causes of severe respiratory distress, but otherwise likely unnecessary in most cases in your office. Otherwise, lots of supportive treatment and oral steroids for croup and asthma only, and antibiotics only for bacterial pneumonia or other infections that you suspect to be a bacterial cause. Hopefully that was helpful, and thanks again for having me and for everything that you do.
Thanks so much, Tasha. Yeah, I think it was a terrific review to help all of us, just, reinforcing to all of us what it is that we're doing. I'm sure most of you are taking the right path, but sometimes there's a lot of questions and pressure from parents to prescribe something. And I think it was really interesting to just have you review everything to reinforce, when it is that we really need to test, when it is that we really need to prescribe, because I think we're seeing so much of it right now. Just to have that clarified is so helpful. I'm going to go to a couple of questions, but just before we turn it to Joan, just to, because I think they're right on topic of what you said. So the first question is from Ralph Epstein, and he asked, what is a reasonable time to monitor fever with minimal symptoms?
Our threshold is usually 5 days. I think fever of 5 days needs to be assessed by a physician and, be that in your office or in the emergency department. I will say that with influenza, COVID, and RSV this season, tons of those kids have fevers for more than 5 days. I think the most important thing is ruling out, a serious bacterial illness, like make sure they're not bacteremic or have a bacterial pneumonia, etc., and make sure that they don't have any features of Kawasaki's disease.
Thanks, Tasha. There are a couple of questions about inhalers. So the first question is from Andre Hollander. Please explain how it's okay to use oral steroids, but not steroids by inhaler for exacerbation of asthma, considering the increased risk of side effects with the oral medication.
I'm not saying that inhaled steroids are not used in management of asthma. So in childhood asthma, depending on the severity and the frequency of symptoms, kids may or may not be on inhaled steroids at maintenance. So if they're not already on it at maintenance, then starting an inhaled steroid at the time of illness is unlikely to be of benefit because excuse me, the effect of it, you're only going to see 4 to 6 weeks later, at which point the illness is done. We've kind of missed the boat. We're no longer preventing a severe asthma exacerbation. Oral steroids, we're using them in a very time-limited course. So the idea is certainly if a kid is having multiple exacerbations requiring oral steroids, then that is a problem and they probably should be on inhaled steroids. Sorry if I wasn't clear about that, but certainly no reason for a kid who's not on inhaled steroids to be started at the onset of an illness just for the duration of the illness. I hope that's clear.
Yes, thank you, Tasha. So Rhonda Wolanski asks, no inhaler for post-viral cough, because I think that's something that, there's buzz about. So what's your thoughts on that?
It's so hard to do nothing. But truly, unless there's a history of asthma or that the initial presentation was in keeping with asthma. Like there probably isn't much of a role for Ventolin. Now, if the cough is lasting for over 6 weeks, they're a child who every time they get a viral illness, they have prolonged cough after, then certainly, yes, that could be in keeping with the presentation of asthma. But for your otherwise healthy child, first presentation of a clearly viral infection, no documented wheeze, and just a cough that lingers for 2 to 3 weeks after, no.
So lots of other questions about post-viral cough. So how about nasal steroids? How about Atrovent? How about this herbal called Alexa Prospan for cough?
No role for nasal steroids. Really, in kids, we only use nasal steroids for concerns of like sleep disordered breathing, adenotensular hypertrophy, and allergic rhinitis. I think off the top of my head, those would be the only times I'd really use intranasal steroids. Atrovent, I think, I'm sorry, I don't know anything about adults, but I think it's used very frequently in the adult population. In kids, the only role of Atrovent is within the first hour of a moderate to severe asthma exacerbation. We don't use Atrovent really at all. There's no evidence even in, an asthmatic who's admitted to hospital outside of that first hour of presentation. So I don't know that there's just no evidence for use in post-viral cough either. And I'm sorry, I can't remember what the third one was.
It was I have to find it now. Oh, an herbal called Alexa Prospan for cough in children.
Honestly, I've never heard of that. If it sounds like there's anecdotal evidence for use and no evidence for harm, then but I can't say I've ever used it personally or ever really even heard of it.
Okay, thank you. So Kim Spacek is asking, is there a maximum dose for dexamethasone? And Alan Grill is asking, what is the deciding factor to use dexamethasone versus prednisone for asthma exacerbation?
Provider preference, I would say. The evidence is pretty much equivocal. Sometimes, again, with the issues with the liquid dexamethasone, it can just be hard to access. Whereas if someone's going to be in hospital for 2 days and we can access that easily, then we put them on 2 days of oral dexamethasone rather than 5 days of prednisolone. But they're pretty much equivalent. With regard to the maximum dose of dexamethasone in asthma, it's 0.6 milligrams per kilo. For other indications, we can go higher, but for asthma, it would be that dose.
So then there's some questions about any tips for avoiding post-tussive emesis in a patient with a lot of cough?
Not really. Like truly, I understand that cough is incredibly distressing and it's very hard to manage. And, it's something that we get asked about all the time. And like I said, if there was truly a good solution to it, then I would be the first person to be recommending that to all of the patients. But really, there aren't a lot of options. Unfortunately, post-tussive emesis typically happens in kids who are coughing so much that they're likely still in the fairly acute phase of the illness. So, I think that's a child who will need close follow-up, monitoring hydration, etc. But I don't know that there's truly like any magical solution to fix that either. And that just keeping in mind that that's also a common presentation of pertussis, especially in the infants.
And then in terms of the Tylenol Advil shortage, Rosemary Lal in the chat recommended considering compounding pharmacies who can sometimes create these custom, but I think Megan Brunskill is saying that sometimes it's very expensive, which makes it inaccessible for families. And is hoping that we can perhaps do some advocacy around that. So I'm going to now turn it over to Joan. I wonder, Olivia, if you can bring up Joan's slides, because I think there are also some questions, Joan, about like, how do we manage this all practically in our office? And so maybe I'm going to turn it over to you to give your presentation, and then we'll go through some further questions.
Sounds good. Hello, everyone. Happy Friday. So like I said before, I am a family physician. I practice in Guelph. I'm part of the Guelph Family Health Team. Just so you kind of an understand of my practice, I have 1,100 patients. I have a good mix, including lots of babies and, children and parents, like the full spectrum. So I'm here to just talk through kind of the practicalities. My hope is if you, like me, over the last few weeks have been like reading the news and, listening to the phone calls and hearing the requests to see more sick kids in your office and see more people in your office. And actually for the last year, all the requests of primary care, just do all the things and all the places. And you've been feeling like you're spinning a bit, you're overwhelmed. You're looking at your crammed schedule and thinking, how am I going to fit more people in? You're not alone. I'm with you. I hear you. And my hope is that this set of questions that I'm going to kind of prompt you to think for your own practice will just help you get some clarity to make a choice and make a decision, and know that whatever you choose, whatever amount of care you decide to provide, and however you plan to sort of structure your day, from your place as a caring family physician who is doing your best to balance 50 bajillion things, that will be amazing. And if it doesn't work out the way you thought, you will iterate and try something else, okay? Next slide, please. The first thing to kind of remind us, in case we're really spinning about this, is like, unlike when we've been asked to like drop everything and do 1 billion booster shots or vaccinate various members of our population, or, things where it's like brand new information, fitting in kids with a possible ear infection or possible pneumonia is like what we have always done. Like way before the pandemic, these were the population that would get that equitable special treatment. And so in case it's feeling like you have to reinvent the wheel all over again, I would encourage you to sort of think back and like rely on old triage patterns you may already have in your office, and certainly reminding yourself like, this is what we do. And like, we just know we can provide higher quality care, not that it's a competition, but we can provide higher quality care in person with these families that know us and trust us, versus the virtual care doctor who last Friday gave a 7-year-old patient of mine that had been fevered for a single day antibiotics and puffers without seeing them in person, right? So like, and no knock on that doctor, it's just that truly like, what level of care can we provide? If I know the patient, I know the mom, I know how to speak to her in a way that she'll understand why antibiotics may not be indicated for this patient, right? So this is kind of care that can feel good to provide. It doesn't feel good maybe right now when it feels like everything is, you're being showered with patients basically. But just as a reminder, this kind of care is the care we've always done and always done well. So it's kind of like opening up our practice a bit for something that we know we're excellent at. This isn't a new skill we have to learn. And especially after this presentation, I'm going to like stop. I feel like I've just got a great refresher from our previous speaker about some things that are going to hone my skills even further. Next slide, please. So the first question to ask yourself, and genuinely, this is my recommendation of the first question to ask yourself, is how can I care for myself and my staff? And that is where you begin in deciding how, if anything, you're going to shift about your practice to make space for these kids. So my recommendation is to not take on more work, unless you were really like coasting this past year. Probably not. You've been doing all the things. This is not about adding more hours or taking on more work. I'm sure you're already at your max in terms of the work you're taking. So this is about reprioritizing versus adding more into your schedule. This is about supporting your staff and yourself to set boundaries against some of the things that are burning us out. So like a couple of weeks ago, I sat down with my staff and explicitly told them, if patients or parents or whoever are screaming at you and verbally abusing you, you have my permission to hang up the phone. It is kinder for that patient, and it is definitely kinder for you. So sometimes a lot of this work is about really making sure we're taking care of ourselves and our team, because we're literally the ones providing the care, and our well-being does have to come first. A practical thing, I saw a question before of how can we handle like the deluge of requests. Having online booking in my office has been very helpful to help decrease the volumes of phone calls. That they're still bananas, but it's helped to decrease them, because then instead patients have the ability to book after hours or book, on their own time and not have to call. It's also equitable for people who have trouble calling during working hours because they're working. And just like finally, like if there's anything that you're doing right now that you hate doing and are only doing out of obligation, this is a great reason to drop all of that, to instead be like, sorry, I cannot sit on that committee I hate, or I cannot, do another disability tax credit form ASAP. I have to go take care of some sick kids. Permission to do that, okay? All right, next slide, please. So just to give you practical sort of tips on like how I'm deprioritizing. Personally, right now, I'm looking at my schedule, and anything that was sort of pre-booked as chronic disease checks, where like, I know the patient, I know they're generally stable, I know they know how to reach out to me if something's going wrong, and I'm canceling those. Anything that's a form or a note, we have an ability, I have a patient portal where someone could access me through there, but forms and notes, I have to decide if they're going to get an appointment or not. They're not just automatically put in my schedule. I am not taking a spot for someone's massage note request. That's something that I can do on other time, in a more efficient manner, and, charge appropriately according to the OMA third-party schedule, right? And prescription renewals, things like this. Next slide. I think that's all I wanted to say about that. And then the last thing is just like, something I missed saying, we could stay on the slide, but I did want to also just describe like how I'm flowing patients through my office, which is just to give an example, not because it's the right example of all time. You know your office, you know your staff, you know your flow. But for us, we have continued to request that all patients wear masks, and we are giving masks to all patients. We are still wearing our N95s and doing PPE that way. And we're seeing lots of people in person, we're flowing them through. So I just wanted to give a quick example of that's literally what we're doing for our sick kids and sick adults. Finally, this one I think is really important. So how can I empower my patients to care for themselves and their families? Like, I think a lot of what's going on, and speaking as a parent myself, a 2- and 4-year-old, so I had my own pandemic baby and saw them both get all the illnesses, including COVID earlier this year, right? How I knew, because I was a physician, what was and wasn't scary in terms of fevers and runny noses and coughs, and when it was time to go to emerge and when it wasn't, right? But a lot of our parents may not have, and they've been steeped in the fear of viral illness for the past 2 years. So how can I imbue more confidence and support the parents of these kids to know when it really is okay to watch their kid at home, and like help them believe that they can take care of their kids through this? That's been a big piece of the work I focused on, especially in the past week. So the first thing I did was steal a blog post from my amazing colleague, Dr. Kate Miller, which I know then got adapted into an OCFP handout about like that we can give to our patients. And so I put that on my website, just saying, when should or shouldn't you call your family doctor? When is it the most important to make sure you're reaching out to your doc, and what can you absolutely manage on your own? And so putting those resources out there, I also shared those resources with my nurses. So when patients are calling in, because they don't even know we have a website, they could be giving them that same information and directing them to our website. I actually also, this past Monday, held a webinar for my patients that talked a bunch about how they can access my care in different ways. And I told them about not screaming at my front staff anymore. And then another thing I told them about was, I just was honest about the state of the emergency rooms as they are now, the ways that I'm trying to prioritize having their kids be seen in my practice, and reviewed what they can do at home. And that is now like a recording that they can watch after as well. Not everyone has to do a webinar, but just trying to think creatively of ways to like almost market and reach out to your patients proactively, sending them an email, like whatever would make sense for what your office already technologically has available to you. putting up posters in the waiting room. There are ways we can kind of disseminate information to our patients that can empower them. And then with each patient, when they're coming in and they're stressed and they haven't slept in days or weeks because their kid just keeps waking up and coughing, now I'm saying stuff that I know you already know how to do, but just to reiterate the power of it, to just validate, share their frustrations. I'm always sharing like, oh my gosh, I know what it's like to like stay up all night with a kid. It's brutal. Are you okay? This is so hard, right? And co-creating a management plan that actually works with their patient context as well. So is it that we're going to do like a phone check-in? Is it that we're going to, like those sorts of things, right? Using I wish statements. So like, I wish I had something that I knew for sure would make you better. If I give you this antibiotic, I'm only going to give your kid diarrhea and then you'll have a new problem to clean up, right? So like using language like that, so they know, like, trust me, if there was a prescription that would help your kid, I would give it to you. And partnering with them in the frustrations that it's hard to find the Tylenol, it's hard to find the Advil. This is what we do. Like I said, I'm not teaching anyone anything new, but just reinforcing the value in what we offer and why I believe that everyone here is already, I'm sure, and can continue to make more space for these kids so that they're seen by the people who know them best, which is us. And then there's just one final slide, which is that everything you offer has amazing value. So however much you're seeing sick kids or not right now, everything you're offering is amazing. And you get to decide how to do this in a way that feels sustainable for you and your team. And thinking short-term, but long-term, like it's so important that we continue to support each other and empower each other as primary care clinicians, knowing our value so that we're not burning out, we're not pulling away, that we know that we have each other's backs and can support each other through these hard times. And that's the end of my presentation.
Thanks so much, Joan. I think there's some comments in the chat that this talk was extremely validating and just terrific in terms of supporting the family physicians on the call. I do also want to mention that I know so many of us on the call are also parents and struggling ourselves with sick kids as we also manage and juggle our own office. I know my own children were sick recently, and even though my children are older, it was still a worrisome and difficult experience that obviously causes chaos for your own family while you're trying to hold it together professionally. So there's a lot of stress for a lot of us right now, and I know we're all doing our very best. And I love that you gave us permission to stop doing some things that are less important, and I think that's really important for colleagues to hear. I'm going to go to the next slide because I think we share on the next slide that great blog by Kate Miller, which is, you can reshare with your own practice patients. I love, Joan, that you did a webinar for your patients to try and educate them because we do need some education for parents. I was reminded of that myself when I was a physician and had a sick child. It's really hard to see your child on day 4 of a fever continue to struggle. And not know that there's no medication that you can give them to get better and that you have to wait it out. And so, parents do need that education and reassurance. Next slide. I'm going to ask Mekalai actually to speak to the next slide, which I think are some new resources from the Ontario College. Mekalai?
Yeah, thank you. So we tried to pull together a number of resources just to help you manage the volume of calls that we know you're seeing in your offices. This one is just a number of tips for how to care for children with respiratory symptoms and provide some guidance on when the child can be managed at home, when the parent should seek care for their child. And I'll just say this was inspired by Kate Miller's post, so thank you for that. Next slide. And the Confused About COVID resource, this one is specific to caring for a child with COVID. This has been updated recently and also a very helpful resource for parents. Next slide. So here is just a list of some of the resources that we recently sent out. So we pulled together a memo to just help patients have some idea of when they should seek care. And we're also trying to get some reminders out there for patients to ensure that they're keeping their masks on. We're hearing from a lot of you that patients are taking their masks off when they're sitting in the office room on their own. And of course, we want to do everything we can to minimize transmission. The second link is just an update to patients that includes a bit of a script. So this can be used as an email if you'd like to do so. And then we have a number of other resources. So just a summary of IPAC measures for your office and ways to try to manage patients with respiratory symptoms. Next slide.
So thank you so much, Mekalai. And I do want to just thank both our panelists who've gone so far. You know, a great back-to-back in terms of reviewing the evidence and thinking about managing practically in practice. I also want to thank all of our audience members for adding some great resources into the chat. In particular, I want to just draw people's attention to the viral prescription that Choosing Wisely developed, also available on the RX Files website too. So thanks for folks for putting that into the chat. You know, I know that there's, you know, debate. There's been, you know, I think what's been hard is seeing so many of these cases in practice and then not being able to do something is really hard. And I think, Tasha, you've helped us to really recognize when it is that we need to take action more proactively and treat through medications and or test versus, you know, reassure, which is in itself, I think, a really important intervention to just reassure and support our parents. So Tasha has continued to answer some questions in the Q&A. So thank you, Tasha. Joan, there may be some questions there for you, I'm not sure. But I'm going to now turn it over to Susy, who's going to give us an update on COVID just more broadly. And then we're going to move to some more Q&A related to that.
Thank you so much. I just want to start by saying, as somebody who works in a hospital and also as a parent to young children, I am so grateful for everything that you do to help protect our kids and our system, because we are really heading into a very dicey fall and winter season, as I know you know, but very, very concerning in terms of what's happening with the epidemiology, which is what I'm going to focus on mostly in my slides today. Next slide, please. So what is happening with COVID? And I'll start off with COVID and talk a little bit about the respiratory viruses that we're most interested in. It's harder and harder over time, as you know, to know just how many people are getting COVID infections out in the community. But our best tools are still to look at what the wastewater signals are showing in the province. Unfortunately, all the data that we have publicly available is somewhat lagging behind by a week or two as to what the current state is. But you can see the trends are helpful. And with wastewater signals, we are trending up, and we never really went down very far from our 7th wave in terms of how much COVID appears to be circulating in the communities. On the right-hand side, you'll see this other graph with the bars as well as a line graph on it, and that's the weekly COVID tests that were completed and their percent positivity. And this is another very helpful and reliable signal of what's happening trend-wise. The number of tests that are performed weekly seems to have stabilized out through most of the summer months. And so what the percent positivity signal is something that you can compare from week to week. And it's been going up. I think it's sort of leveled off slightly compared to the previous weeks at the end of October, but it's still in a high range. And most of this is driven, as you can see in the bottom slide here, by individuals who are older who are getting infections with COVID-19, particularly those over the age of 80. Next slide, please. And what this translates to is, of course, the concern that we're going to see more severely ill people coming into hospital because the older individuals in our communities are getting these COVID infections and are at most risk. Hospitalization data, probably the most useful graph here for the overall state of affairs, is in the top right hand, that figure 7. This comes from Public Health Ontario, epidemiologic summaries that are put out on a weekly basis or so. And you can see that we seem to have stabilized a little bit, maybe peaked with our COVID hospitalizations right now, but look at the numbers. We're talking about peaking at around 2,000 people in hospital with COVID, which is high. That is high, and definitely having impacts on our other medical care. And again, on the bottom, you can see that this is driven largely by older age groups that are now getting COVID infections again. Next slide, please. Now, how much of this is actually driven by any change in COVID itself? Probably not much. It's mostly behavior driven at this point, and waning of immunity from vaccination. And of course, the features of the circulating variant BA5, which continues to dominate in Ontario. However, our genomic surveillance, which continues to give us really rich data on what's happening and what could come next, is showing that the BA.5 subvariant of Omicron is likely to be overtaken by BQ.1 and the BQ.1.1 subvariants. These were derived from BA.5, which is some good news, I guess, in terms of the potential for cross immunity, but they are quite immune evasive. So the possibility of reinfections continues to rise with these types of variants now emerging. So those are depicted in this beautiful graph by the orange lines and segments. And you can see that by the middle or end of this month, we are likely to see more BQ.1 or BQ.1.1 compared to BA.5. Next slide, please. Now, what's happening with vaccines? This is one of the things that we've been relying upon to try and protect people from severe illness in particular, because they have held up against that one outcome over time. Unfortunately, we are not seeing a lot of uptake with the booster doses, 4th doses and 5th doses and beyond, for those especially who are immune compromised and may have reached a point where they would be up and eligible for a 6th dose of vaccine. And I think a lot of this is driven by, multiple factors, the vaccine fatigue, people truly not understanding why or when they need to have their booster doses, as well as people having infections and actually being in the waiting period or feeling as though, I'm protected by my natural infection now, so this wouldn't be the time to come forward for my booster uptake. So it is multifactorial, but I do think that as we head into the season, it's going to be important for us to continue to encourage people to be up to date in their vaccinations for COVID. Next slide, please. So that's a little bit of a snapshot on COVID, but other respiratory viruses really are kind of the focus at the moment because they're driving a lot of infections in the community, particularly in young people, but also leading to what we're starting to see as a real crisis in pediatrics that we have not seen before. And, the system is having to respond to this as a whole in order to accommodate the number of pediatric patients that are presenting to hospital and requiring hospitalization and ICU admissions. And the system is very tight right now, very, very tight. And I get a little insight on that through the GTA hospital IMS, some of the regional structures that have been put into place for COVID management that are now pivoting to help deal with this overall crisis with capacity. So respiratory viruses, our major concerns are, of course, influenza and RSV, but things like parainfluenza and other respiratory viruses, metapneumovirus, for example, can result in hospitalizations, especially with the extremes of ages. And with influenza, you can see that bar graph as well as line graph on your left-hand side, figure 2. We are seeing a sharp rise in the percent positivity of those being tested, coming up positive, particularly for influenza A. And the vast majority of what we're detecting in the province right now is H3N2, which does tend to lead to a higher risk of hospitalization in those who are elderly and have comorbid illnesses. Also some children, but it is a concern for the elderly as well. So we're likely to see, following this pediatric sort of rise in cases in hospitalizations where severe illness being detected, following that, a peak of adults who are also having severe outcomes as well from influenza. Now, RSV is shown in this little line graph here. It is also rising. It's about 5.96% positivity at the moment, so lower than influenza, but higher than what you would normally see seasonally at this time of year. And enterovirus, rhinovirus, which was causing most of the summer colds and symptoms that we were seeing earlier this year, has been declining, which doesn't usually cause more than sort of sniffles for most people or minor symptoms, but still important to watch. Next slide, please. So what's new? Let's talk a little bit about vaccines, first of all. So I think you've already had some discussions around influenza vaccines, but just very briefly, this has been available to the general public since November 1st. In this province, we do cover the cost of it. It's available to anybody, and we absolutely recommend that anyone over the age of 6 months get their influenza vaccine, especially this year, and especially if you're at risk for any of the complications or severe outcomes with influenza. I know that's been covered in a previous session, so I won't go through that here. It has not changed. Nothing's been added to that list of high-risk individuals this year. But the NACI statement on influenza vaccination, which I would urge you to look at if you want to be up to date, has great information in it, has had a couple of updates in which 2 other influenza vaccines have been added to the list of what's recommended and now available to Canadians. Flu-Selvax, which is a quadrivalent mammalian cell culture inactivated vaccine, so not grown up in chick embryos. This is available now for those aged 2 and above. And then a quadrivalent recombinant vaccine, it's a first influenza vaccine that's developed with this technology, is now available for adults as well. And so they are integrated into the recommendations as well. You can give influenza vaccine with COVID-19 vaccines for those who are over the age of 12 years, just to make it efficient, because really we need to just take the barriers down to getting vaccines out there and into arms. And unfortunately, we don't really have any data on what our uptake is so far, although they're collecting that information preliminarily now, as well as the effectiveness, which we know we don't hear about until the season is pretty much over, but is helpful at that point. Next slide, please. COVID vaccines, also in the last month and a half, there have been some updates. So just to kind of round it all up, there's nothing in the last week or so that's changed, but to remind you, there are 3 available vaccines in Canada. There is the Moderna bivalent that was first approved, and that includes the original sort of variant of COVID, of SARS-CoV-2, and the BA.1 subvariant of Omicron is included in it. And then there was the Pfizer that had the original and the BA.4 bivalent constitution. And most recently, this was just on November 3rd, so I guess just over a week ago, another Moderna bivalent was approved, which has the original and the BA.4 Omicron subvariant coverage. Now, if you look at which is recommended over the other, ultimately, NACI has taken the position that, in general, a bivalent vaccine is better than just getting another booster with just the original. And the reason is our goal is to try and have a more diverse immune repertoire and response. And either one of these bivalents or any of these bivalents will achieve a broader response. And so, right now, there isn't any data to say, although we know the more common circulating variant is BA.5, there's not the actual data to say it would be inferior to get the Moderna BA.1 bivalent, because it is an Omicron subvariant in there. So just get whichever of them is available to you, and that's really what we're going by. One thing to consider is that the Moderna vaccines do have higher antigen load than the Pfizer ones, and so we don't really know what this means clinically in terms of effectiveness, but the safety profiles are the same, but you will get more reactogenicity with the Moderna bivalents likely, so more side effects locally potentially. Next slide, please. And then what about RSV? This was kind of exciting news. Again, it was released by press through Pfizer, and we haven't seen the clinical trials yet published, but the top line results from a phase 3 trial of an RSV vaccine candidate showed some very promising results recently. 81.8% efficacy against severe medically attended lower respiratory tract infection in infants from birth to 90 days of life. And it goes out to just under 70% as you go to 6 months of life. And this involved recruiting over 7,000 pregnant women who are randomized to either get this intervention versus placebo in the 2nd or 3rd trimester of their pregnancy. And the intervention was a single dose of this vaccine. And then the children who were born were followed up for at least a year. Many of them reached the 2-year endpoint in order to get these results. So these were the pre-planned interim analysis results. The full trial is not completed yet, but they will be publishing some of this. No safety concerns yet. It has involved diverse populations over the course of a couple of seasons, actually, during the pandemic when there still was RSV circulating. So they were able to get that endpoint. Not yet available, but something for us to be watching. Next slide, please. Finally, I just wanted to end off on what else is in our armamentarium this season, and antiviral treatments for influenza. We've talked about Paxlovid in previous sessions. I know you've heard about it, and there's one I believe that's coming up soon that will address this a little bit more. So I won't say much about Paxlovid, but in terms of influenza, there is oseltamivir, and the neuraminidase class of antivirals are still preferred over anything else for treating influenza. The approach that's recommended by the Association of Medical Microbiologists and Infectious Diseases Canada has remained the same from last year and the year previous, where empiric oseltamivir is recommended for symptomatic children or adults who are at risk for severe or complicated influenza, regardless of the time of symptom onset. I know we focused on the 48 hours a lot, but because there could be benefit beyond that in those at highest risk, it is still recommended. And so age alone is not considered a high risk category, although you can consider consider it in young children. And another thing to note is that higher doses of oseltamivir in adults is not really supported by much evidence, and so it's not really recommended. And a note that, again, resistance is uncommon here. So in Canada, so it is something that's usually affected. So I'll stop here because I'm sure that there are lots of other questions that will need to be addressed. Thanks.
Thanks so much, Susy. Yeah, I think why don't we go to some questions to start. I do want to just point out to our audience members that some of you have a lot of questions about the flu shot, and Dr. Alison McGeer did go through that in more detail at our session a few weeks ago. And I think some of you are also talking about, how do we convince parents around parents of young children to get the COVID vaccine? And Dr. Janine McCready kind of addressed that quite well at our most recent session. So you can definitely rewatch those sessions. And I do also want to just emphasize, I think some of the take-home points that we've heard over and over again is that, of course, prevention is best. And so, we need to encourage our patients to get vaccinated, to wear their masks indoors, especially in crowded settings, to wash hands and to stay home when sick. And I know we're all trying to do that. And, I think many of us are also advocating for potentially limited mask mandates coming back. And I'm just going to put a paper in the chat that recently was published that I think is relevant to this. The other thing that I wanted to raise was there's been some chatter about the co-administration of COVID and influenza vaccine, Susy, and you talked about that. So I think the latest recommendations is that for anyone 5 and older, it's okay to co-administer. It's for those under 5 that the recommendation is not to co-administer, but it's a recommendation out of an abundance of caution to assess for potential safety issues. I think folks asked if there's any evidence around that 2-week interval. I don't know if there is evidence that guides the 2-week interval really between when kids under 5 are supposed to wait, but between their COVID and influenza vaccines. But it is a recommendation and not something that you have to do. So that I just wanted to clarify a few of those points, and then I wanted to go to some of the points in the Q&A. So a couple of these are actually for Tasha, and then there's one for you, Susy. So I'll start with the one for you, Susy, which is, how good a match is this year's flu shot to actual circulating influenza?
Oh, it's a great question. I very briefly kind of glossed over this, but unfortunately we can't calculate vaccine effectiveness against the currently circulating strains of influenza until much later into the season. So typically sometime in December, we start getting some interim data on what it looks like, but then the final sort of vaccine effectiveness is calculated in February. So not helpful for what we're experiencing right now. We might get some of that a little bit earlier this year because of the intensity of influenza that's happening earlier. What I can also say, though, is that in Australia, where they had an earlier flu season and quite an intense one, it appeared as though their preliminary data shows that it's a fairly good match for the H3N2 component of the vaccine. So I'm hopeful that we'll get some good coverage.
And Susy, I'm going to ask you, can you also comment on the evidence for 4th dose in teenagers? What about the risk of myocarditis for them?
Right. So, I mean, I think the previous recommendations around Moderna and using caution still apply. However, we haven't seen any safety signals that are sort of additional, and it's been pretty well tolerated in all age groups with the additional booster doses. So nothing new has emerged, to my knowledge, that should be added into that sort of consideration for side effects and adverse events. But the recommendations are exactly what's being rolled out, what's being communicated publicly in terms of the duration of immunity does have an endpoint. We do have waning immunity, and so the booster doses should be considered with adolescents as well.
And then Eileen Comerton asked, my understanding is that an egg allergy is not a contraindication to the flu vaccine. Can you confirm whether that's the case, Susy?
That is correct. That's been for several years now, where it's no longer considered a hard contraindication. I think for people who've had more severe reactions to, egg products or who are concerned, it is recommended that that immunization occur in a physician's office or somewhere where they can be counseled and sort of, I guess, monitored a little bit. However, it is not a hard contraindication. I think you have to assess the kind of allergic reaction and what the risks would be overall for that individual. But there are also some other options, as I kind of mentioned, that are coming forward. So that might end up making this a moot point for people who are concerned about their previous allergies and reactions.
Thanks, Susy. And the last question for you, Alan Grill is saying, can we push Dr. Hota on whether Tamiflu really makes a huge difference in preventing hospitalizations in outpatients, considering we are guessing about the diagnosis?
It's a really tough one, like the recommendation for empiric treatment for those at high risk. Like there isn't great data to show what that overall outcome will be. But what I will say is, even in the face of uncertainty, if we've got a kind of season like what we're looking like we're going to face this year, it is warranted in my mind. For the most part, oseltamivir is well tolerated. In treatment, it doesn't seem to encourage resistance development if people are completing their courses of treatment appropriately. The exception is in those who are immune compromised. That's where we are probably seeing the development of resistance kind of as the virus continues to persist a little bit longer, and also when it's used for prophylaxis. So I'm very cautious in those kind of settings, how we actually approach it. But at the same time, you have to balance this against what's happening with severe illness in the overall system. So yes, you're right. The evidence is not that clear in terms of how much you can actually prevent hospitalization for when you're using it empirically like this. But I think the current thinking is it's probably worth the try.
Thanks. And so just to clarify for folks again, if you missed it, that if you're counseling around the COVID vaccine, people should be waiting a minimum of 3 months since they last had COVID or since they last had their last COVID vaccine. And you can co-administer COVID vaccine together with any other vaccine, as long as you're over 5, or 5 and over. If you're under 5, then there is a recommendation to space it out by 2 weeks, just as through an abundance of caution to detect whether there are any safety signals. So just wanted to re-review that because there seems to be some questions about that we continue to get. So Tasha, I'm going to go over to you with some questions. So Julie Behoon asks, there seems to be a lot of conjunctivitis around. Is this all viral? Many patients are presenting requesting topical antibiotics, especially since the over-the-counter polysporin is not available to get from pharmacy. Should we just wait and see, if it resolves, or is there an indication for a topical antibiotic?
I think if you're confident that it's viral, so if there are similar symptoms in other people in the home, it's bilateral, it doesn't look too bad, not super purulent, I think watchful waiting is totally appropriate. Oftentimes, actually, OXO will start them on antibiotic eye drops to prevent secondary bacterial conjunctivitis. So I think that would be a case-by-case decision, but certainly if it's bilateral, it's kind of, other viral symptoms in keeping, I think watchful waiting would be appropriate.
Thanks. Heidi Chestnut asks, can anyone comment on non-strep bacterial pharyngitis? I had a patient with a bad sore throat, strep negative, twice, and they didn't look like an abscess. They went to the ER and actually saw ENT, and they were told to let her family doctor know that they're seeing lots of bacterial non-strep pharyngitis, and they treated it with clavulin. So I don't know, I guess that's a question for both you, Susy and Tasha, because I wasn't clear in Heidi's question whether it was a child or an adult. And if you don't have an answer, that's okay too. You can just say you're not sure.
Yeah, I mean, I think this is one of those questions where the details probably matter quite a bit. I will say there are other bacteria that can cause pharyngitis and also abscesses. So, that might be the case, but I don't know with this particular scenario.
Great. So.
Oh, sorry, I was just going to echo that and, question how they knew it was bacterial versus viral. Like, I do think that probably there are some details there that are missing, but certainly viral pharyngitis is the most common cause of pharyngitis. And so I don't know if that was maybe an overtreatment or there were just some things that we weren't getting on the details there.
Great. So then Julie Bahoon did also ask another pharyngitis questions. I see patients coming back from ER with a single dose steroid for acute sore throat, viral strep not proven. Is this helpful? Is it standard of care? Again, I'm not sure if that is adult or child. And Liz Muggah, actually, do you want to speak to that, Liz? Because you said that you were actually has seen that in your own patients as well, and put a link to the meta-analysis.
Oh, I would totally defer to the experts who are on the call, but I can tell you my understanding is that it doesn't do anything for the virus itself. It's just pain treatment, and it doesn't change how fast you can go back to work, how fast you can go back to school. Really, I that's my family doc analysis. So I defer to the experts who are here around the table.
I was going to echo that. I think it's all for symptomatic and sort of, to take down some of the acute inflammation. The problem with that approach is it can rebound after the steroids leave the system. So it's a very temporary measure.
Thanks. So then, Tasha, I also wanted to, I think there was also some sort of questions and dialogue really just about flu in kids. And, I think you didn't specifically talk about influenza in kids. I don't know if you wanted to just say a few words about that. And similarly, if you wanted to say a few words about COVID in kids, and even some folks are wondering, how good is a rat in children? And, is it practical to encourage that kind of testing, and what circumstances?
So I'll start with influenza. I think I did answer the question in the Q&A. There is evidence for use of Tamiflu in kids over 1, in particular those who have severe disease. So anyone who's hospitalized with influenza or suspected influenza over 1, typically we would start on Tamiflu. Now, there is kids between 1 and 5 are considered high risk for developing severe influenza. And so in an outpatient setting, the recommendation is that Tamiflu can be considered. Now, I don't work in an emergency department or primary care setting, so I don't know in reality how often that option is being used. There is a good Canadian Pediatric Society statement that actually has listed the risk factors, as well as kind of a bit of a decision tree on whether or not to use Tamiflu, and I can find it and link it in the chat. With regards to COVID, I will say we're not seeing very many hospitalizations of kids with COVID anymore. It's mostly influenza and RSV at the moment. I know someone did ask about the use of steroids in COVID, and currently the recommendation is oral dexamethasone for kids who are admitted with COVID, so severe enough requiring hospital admission, but certainly not as an outpatient. With regards to COVID testing, so I think the main issue that we encounter with rat testing is that parents typically don't go deep enough. We retest everyone in hospital anyways. We now have combination like COVID and RSV influenza swabs, which is really great. And we have results very quickly. So I would say, anecdotally, my experience is that I don't think parents are testing much anymore, at least for the kids that we're seeing in Emerge. So I can't really speak to rat testing. Yeah.
Thanks so much. I think there is a follow-up question just about coverage of Tamiflu. So I don't know if either of you could speak to Tamiflu if you have no. So I don't think Tamiflu is covered. And Liz, I don't know if you want to actually clarify this question because I think you saw it.
Yeah, so my understanding is that the Tamiflu is not covered by ODB, and not, so I just was curious how you manage that, because it seems like the criteria is sort of from what we're doing currently in the community, which is very few people are being treated. It's mostly the long-term care setting, and what the guidance that seems to be shifting more towards, from what I'm hearing, more treatment. How do you manage that? Because there'd be lots of patients who wouldn't have it covered. But honestly, I prescribe it so rarely, so or almost never, basically. So I'm, other than in a long-term care setting. So just wanted to get your insights on.
I'm not sure I have any insights. I'm so sorry.
No worries.
It is a problem with, the recommendations say, yeah, you should be treating people empirically if they have high-risk features, and yet until they land in the hospital, it's not really, financially accessible for some.
Yeah, it seems like an area that maybe we need to get some more clarity on in general. So thanks, Tasha, for posting the link in the chat to the Canadian Pediatric Society guidance. I noticed that others also have posted some useful information in the chat as well. So thank you always to our panelists. I wonder if, Olivia, if you could put the slides back up, and we're just going to run through some of additional resources that we think might be useful for folks. So I think these are resources that, again, the OCFP has put together here. We know that many of you have been struggling with patients potentially being aggressive or, just very adamant about not wearing masks. Hopefully these printable signs can be helpful for you in your office in trying to counter that and set a tone of what is acceptable and the standard that you're expecting. Next slide. Also wanted to highlight this OCFP resources to support just what kind of infection prevention control measures you should be taking in your office. We reviewed these in detail in our last community of practice, which was 2 weeks ago. So if you missed that, you can just rewatch Janine McCready's portion of the talk to review that. Next slide. We also, at our last session, mentioned a number of OMA resources that are really practical. So some of you have been asking, which influenza should I choose? Which influenza guide should I choose? And this product from the OMA can help you to know which one you can be selecting for your patients. More confusing is the COVID vaccine situation, I think, and this reference tool from the OMA is also very useful from that regard. Next slide. And then there's some resources around personal protective equipment, as well as how you can do testing in the office. Next slide. And I think one thing that was, and then we have also updated our COVID booster on Confused About COVID guidance. So if you wanted to provide that to your patients, a great resource. Next slide. And then I think some folks on the community practice last time mentioned that they are sentinel physicians for the influenza vaccine program. And this really allows them to actually have access to testing for influenza within their outpatient setting and helps them to manage their own patients. So something that you can consider signing up for. Next slide. And then these are just some additional resources. So we'll have these available. Next slide. And we're going to wrap up now, and I'm just going to share a few last opportunities. So as usual, we are always looking to make these sessions as effective and useful for you. We try and keep our ear to the ground in terms of what it is that physicians want to hear about, what the struggles are on the front line, so that we can bring you CME that is continuing professional development that is aligned, timely, relevant for you. And to help us do that, we're looking for folks to join our planning committee to bring different perspectives from different regions, different practice models. We also love featuring family doctors from different areas of the province. And if we have more people on our planning committee, we can have a wider reach and being able to tap people who are doing really important and interesting work. So please do consider joining our planning committee. We'll put that email in the chat as well. Next slide. A few more opportunities. Our department has pulled together a new series to support people to, do quality improvement in practice. We think this is particularly useful for folks who are tapped to do their CPSO QI program requirement. And we're looking for reviewers, and happy to pay you guys an honorarium. So please do contact us if you're interested in being a reviewer for our online module. Most people I know don't need another thing to do, but if you are looking for, if you are interested in gaining this knowledge yourself, we'd be really appreciative. Next slide. FMS is now also, registration is open. So we'll put the link also in the follow-up, but it should be a great session, a series of sessions in January. Next slide. And then I wanted to remind folks that we do have a complementary community of practice called Practicing Well that really focuses in on mental health and addictions, and talking about physician mental health as well as patient mental health. And you can see some of the upcoming topics that are listed there. And I hope that you'll consider joining that. That's why we don't feature mental health as much in our own community of practice here, because there is this separate community of practice that really does a deep dive. Next slide. So I want to end just by saying a huge thanks to our panelists. So thank you to Susy Hota, to Tasha Stoltz, to Joan Chan, and to our co-hosts Mekalai, Kumanan, and Liz Muggah. All of you are yourselves very busy in practice, and appreciate you taking the time to provide your expertise to us. I know myself, I might myself be going back to this recording just to get a refresher again on in case I've missed, missed things. And I hope that all of you know that you can go back to the recording. It'll be posted at the end of today on our website, together with the slides and the resources. And usually just a few days later, we'll have the Q&A up as well. So thank you to our panelists, thank you to our back team who make this all possible. And then of course, thanks to you, all of you who are attending, who really make this community thrive and who are working hard every day in practice. Thanks very much, and see you in a few weeks.